Walk with me as we take a broad-ranging tour of the world of cannabis, from the ancient to the modern, the medical to the recreational, as well as the social, cultural, and political landscapes of this fascinating plant. I am Dr. Jake Felice, and this is the Cannabis Matrix, where cannabis science meets cannabis culture, where recreational meets medical, and where the body's own endocannabinoid system is as much a player as CBD or THC. Welcome.
That's what I was going to share with you guys about this. There's this book called The Future Public Health. This first author, Phil Hanlon, and he's a Scottish physician, MD, but works for the National Health Service, and for many years after working in other kind of prevention and international medicine. Anyway, these guys are it's really cool. They've written a bunch of papers. That's how I first heard about them. And now they wrote this book a few years ago, and they have some videos that explain their take called After Now on Vimeo. You can find a couple of their five videos with it. So basically, they and I try to cover this in these chapter that I wrote for Dominic Corva's Cannabis Post-Prohibition Handbook that's coming out on Routledge.
Good way to go, Dom and Sunil.
Oh yeah, Dominic and the guy at Humboldt State University, Josh Meisel. They really brought some cool folks together, looking at different aspects of post-prohibition situations. Anyway, so in that chapter,
can I interrupt you just for a second?
Yeah.
It's been a really long time since we talked, and I'm reminded, it's like, oh wow, I forgot. Sunil isn't just a doctor; he's a really smart person. He's really intelligent, not like a regular doctor. And so, huh?
Oh no, I was gonna interrupt too, but I want you to finish your thoughts, Sunil.
Yeah, I just wanted to pepper that into your video feed because
I want to listen. All of us have done medical clinical training, but then realize the severe limitations of the system and model to do the healing health work at the social and individual and family and community level. It's very much, that's why I did the MDP. I knew that the system was messed up. I already had a parent who'd been in medicine. So I kind of knew, all right, well, this is where things are at, and maybe we can make it better. But that's where I got interested in this whole public health and human environment relationship as it applies to health. Actually, because that was an easy place to study cannabis, actually, where it was much harder to do any cannabis research in the lab, because you wouldn't have time to wait for the approvals that they made you jump through, just to study an herbal, an ancient herbal medicine for pain or cancer or whatever you wanted, neuro, anything. It was all very much so that's sort of how I kind of fell into it, as an area that you could look at things a little differently, what's going on the ground. Anyway, so public health is really an interesting, important field, and I've been on the American Public Health Association, one of their listeners, for a long time. It's a great field, and they talk about the four waves of public health throughout the history, and really late 19th century to today, and they talk about how we kind of we're built on top of each of them. But now the situation in the world, we need this fifth wave of public health. So that's sort of and then I just wanted to tell you what those are about a little bit. So as far as I can remember, and because I think it shows us also the progress we've made, from the old days when people would die of some outbreak in the Industrial Revolution, or just cholera. Mixing feces and whatever, milk, contaminated water. And
I'm not sure what the four waves are, Sunil, but I'm remembering that two major things: clean drinking water, and adequate food are responsible for about 70% of the life gain in terms of life expectancy from 100 years ago, when people were living 45 years or whatever. 70% of that is those two things: clean water and adequate good nutrition. About 20% come from the antibiotic revolution, and the remaining 10% was all the other drugs and surgery and procedures combined.
Yeah, but you didn't factor in all the people dying from medicine too. You got to subtract all.
Right. Well, I mean, that's the thing, is that medicine has co-opted the gains in human health that actually came from public health, and people don't realize that they were public health measures as opposed to medical measures. I mean, even, as controversial as a topic as it is, vaccines, that's public health. That's not medicine. Just because a doctor gives the injection, that's not something that you go to the doctor and the doctor says, oh, I think given your condition that you're 3 years old and you're about to go to school, you should receive this medication. No, those are public health mandates. And
Right.
and so the one thing that was left, that you left out, that figures in there somewhere, Jay, is public health regulations regarding housing and the number of people that could live in a single unit, and how many families can live in an apartment that has just one bathroom or whatever, all those sorts of things. That also stemmed a lot of communicable disease and other issues. One thing, if I can just throw it in there, is that I also think that medicine takes credit from public health, because it took me a long time to understand where that line really should be drawn. But I would say, I don't think I've read it anywhere, but I would say that clinical trials are public health. It doesn't become medicine until doctors start to employ, say, a new drug or a new protocol, until they start to implement that in the clinic and it becomes clinical practice. Then that is medicine. But
Right.
the construct of requiring clinical trials or choosing to use clinical trials as a way of justifying making shifts in medical care, that's public health. And the very fact that you use statistical analysis on large populations, that's the antithesis of individual treatment. And so it's a funny thing, because I don't know if it's like the snake eating its tail or what metaphor, but individualized, personalized care in medicine. I have a graphic that I created because I'm a big proponent of using big data to focus on individual issues. And my magical, erudite phrase is e pluribus unum. And to take the insights gathered from huge pieces of data and from maybe even huge populations, and then seeing how can you apply that to an individual, but treating that individual as an individual and not as belonging to some particular part of the bell-shaped curve that we have no way of knowing whether they belong to, because the clinical trial was run in Croatia and my patient is Haitian and living, in Iowa. And so it's like, does that study really apply to that person? So that transition from a public health insight of a clinical trial and to translate that into a clinical N of one decision, to me, that's something that's done rather imprecisely.
Yeah, that's a translational, that's the field of translational medicine or whatever.
Yeah.
And I was just going to tell you, in my training in the medical geography, I studied, there's a book, Clinical Epidemiology by Noel Weiss, who was here, and my mentor, who was both a professor of public health and geography, Jonathan Mayer, he was like, he was very, like, the entire book was all like design of trials, like, because it's under clinical epidemiology is like both case control studies, retrospective, prospective, all like the randomized trials, controlled trials, all these various different types of trials and designs are coming from the field of epidemiology and public health to assess risk benefits, in certain whatever settings you have. So definitely public health is really important to medicine for the goals that we want, and they need to go hand in hand much better. And I've always wanted to think of myself as a public health doctor too, that, we're acting, as you say, from the many, which is like the data, the understanding of what's going on, and what the needs are from a public health standpoint, and understandings are, I guess, and then translating that into, well, how does that apply to my particular patient who has some of these features but not these other ones? So how do you kind of that's the practice of medicine. That's the part of the art and science of it, is knowing how to make those movements on scale. So anyway, I just want. Yeah.
I was just going to add one little addendum. I think if you look at the history of medical experimentation, like I was saying, that clinical trials are more of a public health vehicle, because if you look at what doctors typically, let's say in the early 1900s, did when they wanted to experiment with a new therapy, they would just try it out on some people. Immigrants, they would give syphilis to a bunch of guys. Yeah, but with no control group, no informed consent. I mean, any of those other things, all those other things that constitute clinical trials now are public health or ethics, medical ethics mandates. They didn't come from the doctors that were curious. It's like, I wonder whether or not, chamomile can help, babies stop crying at night. They would just give it to a bunch of moms and tell them, just give it to your kid and then tell me how it went. That's not a clinical trial.
It's observational understanding. Sometimes you can do if you do it in try to do something systematic about it. But I do think ketamine, which I use a lot in my practice, I recently prepared a talk and found the first trial that was done in humans with ketamine was done in prisoners and by the company, by Park Davis. Edward Domino, I think, was the principal investigator. And I don't know what prisoners they used, and if they knew, hey, you're getting this new PCP alternative, like, are you cool with that? I mean, it might change your awareness of like why you're in prison, or you want more time in the gym. Well, maybe you should do this trial. Like there was probably all kinds of terrible and perverse incentives.
Yeah.
I mean, I would have done it too. But anyway, that's just an interesting aside in terms relevant to what you're saying. I thought you just coming back to the public health thing, like this is what these guys have, and they use this based on the UK's public health. It's kind of hard to see on the screen, so I'll just read it. So they talk about these 4 waves. The first wave, they say, from 1830 to 1900, and again from the UK perspective, but this sort of can apply in the US as well and other places. Classic public health interventions such as water and sanitation, was where a lot of that was happening in the first wave. The growth of municipal power and influence. The second wave was 1890, they say, to 1950, and they call this sort of the rise of scientific rationalism, providing breakthroughs in many fields, manufacturing, medicine, engineering, transport, communications. They also describe the building of hospitals, the generation of different medical specializations within hospitals, and kind of also that sort of the idea of viewing the body as a separate machine with different like parts of it. It's sort of in this second wave where hospitals and all these things are built. And then the third wave, they say 1940 to 1980, is the emergence of the welfare state and post-war consensus, and that includes social security, social housing, universal education. These things are obviously, we're not like, this wave is not completed, but it's like the idea that, okay, this is the thing we need to like do now, in like, because there was no programs. People don't realize like how recent some of these things we take, Medicare and pensions and whatnot. So that's wave 1. That's wave 2. Wave 3 we just talked about, and then wave 4, they talk about the rise of the life. Like this is what was happening when I was going to school, is the emergence of risk factors, lifestyle interventions, behavioral interventions as a way to mitigate disease. Smoking, exercise, diet, lifestyle factors, risk factors and lifestyle factors become a central public health concern. That's 1960 to the year 2000. And they kind of say, hey, these are the 4 waves over time, and they each build on each other. We start from that wave and we build on the next one. So they say that this has been great, and they go through all like the pluses and minuses and what's happened in these different waves. But they say that really what's happening now, the situation in the world, there are so many complex and intersecting problems that we have, that just these public health that's currently structured is not set up in any way to tackle them in the systematic way that they are. And the problems they point to are rising obesity, rising sense of depression and anxiety and addiction in the world. They talk about rising income inequality, haves and have-nots. They talk about the huge impacts of global climate change, global breakdown of all the environmental controls that we were talking about earlier. They talk about it's just you could think of like I would put into that list, and this was written well before coronavirus, rising pandemics. I would put into that rising violence, like levels of social unrest and violence and mass violence. These are like some of the more complex problems, and we could probably make a larger list. I've got a list someplace in here, but what they say is that these problems they say we now need to move into this new wave, which is centered on well-being and what it means to be human. Like it's like we gotta because they sort of say a lot of the central issues in here have very much to do with this sense of loss of meaning, loss of centralizing well-being in some way, people working in a system they're not happy with, and all these kind of things, and then the capitalism, like the run amok, turning into the climate change, making the climate change situation work. I mean, they really kind of break it down. So what they mean by that is like, they really talk about this new model for future public health, where you really think about a 4-box model. You look at the inner, this is very integrative. It's like the inner dimension of a human being, the deep inner well, and then the inner, and you think about the health as it relates to the inner social realm, like mythology, archetypes, and all that stuff, collectively inner. And then you have the external, outer at the individual level, which is what we all like, physical medicine, and like, that model of medicine is focused on that corner box, just individual external, view. We don't really, like the other stuff is a black box, and we don't. And then the fourth one is external group level, which is sort of traditional public health measures of sanitation, water, infection. Like I got to get this virus off my tongue or whatever, and out of my prevent physically. That's what I am. I'm just a vector for viruses, but I'm so many other things. I have these other three other dimensions that are ignored in that. So they say you got to bring in, and then he uses the analogy of I believe it's like Plato, and they say that Plato had this idea that really this maps into the true, the good, and the beautiful. Like he said, like all knowledge.
You're talking about Plato, the Greek guy, not Plato, the stuff that you can buy and give to your kids.
No, Plato, right? Like to get into the realms, like they talk about the importance of beauty and aesthetics and how you have to have that, because people are driven by beauty and aesthetics. We think we're just all driven by dollars or whatever incentives. There's actually a lot of other things that drive people: connection, community, blah blah blah. But beauty is one of the things that they highlight on, aesthetics, and they give some really concrete examples, like why do you do a certain thing? You need to understand the science of it. So that's the true, like what is factual, the good, like what is ethical, what's appropriate in terms of like allocation of resources or whatever, that system of ethics. And then the beautiful, which is like, what is it that's like tying, like, is this like something that's going to make the world a prettier place, whatever that means, like, or for this individual, make their life more rich, or, that's sort of a little bit more of a nebulous thing. I think a lot of individualized factors, but in palliative care, which is what I trained in, like, we very much have always kind of looked at that meaning and purpose box as part of an assessment, because somebody's going to have a miserable and like last few weeks of their life if they're dealing with a terminal illness, if we're not attending to all of these things all together, because those become serious situations where that box, if it was neglected, as those two boxes, will completely ruin that patient's quality of life, their symptom burden, their hospitalization, the family who lives on afterwards. So I'm just kind of bringing that into this, and they're saying, like, let's apply this whole thing writ large. They give like examples, and I feel like if we can get into like that kind of mode where public health is a lot more engaged in some of these more complex interlinked problems, we're not just in these little silos, like, oh, I'm just going to vaccine our way out of this problem. If that's the Gates. I mean, I was here when the Gates Foundation started, when the Global Health Department at UW started. I was in school, and they came to ask us to give us input as the students, because I was like global health pathway at the U, and you know, everything that we suggested was all, you know, ignored. Ultimately became this much more technocratic thing. We were talking about some of these more systematic approaches and issues, but that's not what happened. And you know, I'm hopeful.
Can you hold on just for a second? Oh, you keep going. I just have to run and do something. Go ahead.
Okay. Yeah.
And Sunil, that just, you know, that whole fifth wave stuff was, I lit up. I was forming synapses because I was like, oh my goodness, and it makes so much sense. But you know, risk factors, lifestyle, exercise, prevention, diet. It sounds like we need a complex and interactive physiologic system to help deal with all that. I wonder what that could be. Something that is involved and is involved in weight gain and obesity, depression, anxiety, the endocannabinoid system, of course.
Wouldn't it be nice if there happened to be a system?
Yeah, and then you even mentioned global climate change. There are papers, and I'm sure Dominic would be the first guy I would call, but with hemp, we could feed the entire planet theoretically, as well as many of our animals with hemp. And it's so good for regenerating soil. It's a carbon-based sink. So this whole idea of medicine being just the THC or the cannabinoid is not just that. It's the whole apparatus that is set up around it. And I know, admittedly, a lot of cannabis is grown indoors, so that eliminates the carbon sink feature.
It's only indoors because of the policies. Like, you know, traditionally before 1980, I'd say 1970, like for like thousands of years until 1980, it was outdoors. And right. Then, and still, what's that?
Oh, and still, you know, the plant is just so insect hardy, and the taproot can go 3 to 4 feet deep, which can aerate. It goes and it finds its own water, and then it aerates the soil so that the next year the soil is better. Just
that's what I've heard. That's what I've heard. Agriculturally, there's absolutely lots of good reasons to use cannabis, and I even had a friend, Paul Hartman, who's a brilliant guy, who was also Humboldt and marine biologist, and he was for years, like 20 years ago, was writing to UN, like on these listservs, UN Food Agricultural Organization, like staple for famines, like you need to get hemp seeds in there. You need to have hemp because that's really going to help with these, like whatever other cassava or other like staples you're using in these famine situations for food relief. That you know, this has this all essential amino acids, complete protein content, and you know, all that stuff.
Lipid profile. It's got, I believe it is a 4-to-1 or a 3-to-1 omega-3 to omega-6 ratio, which is what an ideal diet consists of. You know, you look at chia or flax or others that have good omega-3s in them. They don't come in that ratio. It really is just a wonderful food. I had toyed for a while with, you know, it's kind of not as cutting edge anymore with Elon Musk and everything, but writing about cannabis in space and the benefits of cannabis in space. It's a perfect food. It's a medicine that can be used
for space
food. But really what that is it's a rhetorical trick, because all of those things work right here on planet Earth. It's not.
Well, yeah, I think hemp seed oil will go rancid at room temperature when you heat it. So I don't know how that'll last.
It does. The oil does need to be refrigerated. It absolutely does. But the hulled seed can retain its lipid profile in sealed containers indefinite. So,
but the shell removed or the shell intact?
Yep, it's technically the hemp seed is a fruit. I think it's called an indehiscent fruit or something. It's kind of like a sunflower seeds, where the fruit part is real thin and it folds off, and then the quote hemp seed is what is underneath it. But anyway, so that's what you're getting when you get hemp hearts or things like that at the grocery store. You're getting.
My understanding is that you do lose some of the oil when you take that hull out of it, like the external shell. I think there's some oil there, and then you get that meaty part. So people used to say you really want to get unshelled, like hemp seeds. That sort of you get the most bang in terms of buck, but it was like impossible to get them. I don't know, in the old days.
I've eaten them off of the plant. That hull is kind of like eating a sunflower seed. You probably, I mean, it probably tastes better with it removed.
I think people used to crush them and make seed cakes. That was, I think that was a traditional way to prepare this. There's all kinds of like, I've heard about people making chutneys still in the Himalayas of India using hemp seed chutneys. There's, my wife, who's an anthropologist, told me about, like, she saw those in places up there. So it's used in other places too. So we were just caring about, like Jake was saying, like, we really gotta, this cannabis and the endocannabinoid system is all really, I think, it's part of this larger wave of public health, because it forces, it's a new understanding that connects a lot of these disparate things in the human physiology. And I think mind, body, spirit, and also maybe even the social level, there's a lot of interesting work on social exclusion and the impacts that has on the cannabinoid tone. And if you actually take cannabinoid booster like Tylenol before you play a psychology game where you get excluded, like there's some studies where they've done this to poor volunteers, like you're playing at something and they're like, oh yeah, you can't be on the team anymore. They just randomly kick people off. But if
they lose their empathy.
Right. But yeah, well, if you take, first of all, when you get kicked off, like apparently if you take Tylenol beforehand, you don't feel as bad. And I don't know if that
that's the empathy part. The empathy part, yeah.
I don't. You just don't care. You're not as empathetic with your, like, if you are more empathetic, you might still feel better or worse. I don't really know. I'm kind of confused as to, because I've also read that Tylenol can blunt empathetic responses.
Right.
But it also
so it blunts empathy. It also blunts performance, anxiety, and assessment of quality of personal performance, kind of similar to alcohol, where people think that they're driving better than they actually are. So
or singing better.
It's actually a pretty powerful psychoactive drug.
Yeah.
Well, yeah, and the whole. I mean, personally, I will take buffered aspirin before I do a big travel, not for the anti-inflammatory aspect, but because I've just found that it really helps my stress as I'm going. The TSA line, that stresses me out. I'm like, are they going to get me? No, I mean, I'm just kidding with that. But I found, I mean, I that's just a personal observation, and I just realized that over a number of times where, I might have had a sore back or a sore neck and I was traveling, so I would preload with I usually prefer aspirin if I'm going to do an anti for personal reasons, but I found it very good for stress relief. And so
that's interesting. I mean, people don't talk about that aspect of aspirin much at all, and could be this the new old understanding of inflammation is really not just Greg Gerdeman was recently interviewed. He's back in Tennessee. I don't know if you guys know Greg. He's a brilliant PhD. You guys know Greg Gerdeman? Have you come across him before? Oh, he's like one of the most brilliant cannabinoid scientists that I've had a chance to meet over the years. I've been Gregory, last name is Gerdeman, Gerdeman, maybe two N's in his last name. He was one of the first people that discovered retrograde signaling in endocannabinoid synapses under NIDA when he was doing his PhD or postdoc. NIH, NIDA grants, so he was really on the cutting edge of cannabinoid physiology understanding in the 90s. And I met him at an ICRS meeting in 2005, and we've been friends ever since. And he kind of then became a professor in Florida, and now he's pivoted into kind of cannabis science officer for companies and things like that. But he's an excellent communicator and educator. He was the go-to guy for explaining at the American Chemical Society special section on cannabinoids what's going on with delta 8 THC and like the whole what's that all about, and like what do we know and don't know. Anyway, so he had recently did an interview. He's back in Tennessee where he grew up, He's kind of moved there, and the local paper, because there's no law for cannabis in Tennessee, or there's nothing really like legitimate, so people are still trying to prevent themselves from going to jail for talking about and using what we're talking about here. I think it's still kind of in that world. I don't know. Anyway, but he was saying the big three for cannabis, that Delta 8 can potentially work for that. He was like talking about pain, anxiety, and then sleep. But then with the anxiety, he says anxiety / inflammation. So like he kind of puts anxiety and inflammation on the same part of the stool, which was it was nice to sort of see that kind of aha that he was.
I like that.
He's saying.
And to tie in with kind of what Karyemaitre was talking about in terms of, do we talk about cannabis in terms of a health model or a pathology disease state model? A lot of the times, what I've been talking about lately is I use those big three, but I'm going to start adding the inflammation, pain, anxiety, and sleep. So many patients with other conditions you have a diabetic patient with osteoarthritis and knee pain that's preventing them from sleeping. Cannabis stands a good chance of helping them sleep, but it might also help with the knee pain and the osteoarthritis. And if there's THCV, it might actually also impact the blood sugar.
Diabetes, yeah.
So many patients have one of those big three. So to utilize cannabis in conjunction, with Crohn's, a Crohn's disease patient just had a hip replacement, 3-4 weeks ago. And is just wanting something a little bit to take fewer NSAIDs. You might be treating a specific problem, but it has global impact. Kind of like what you were talking about with the fifth wave, all of these things we see interconnecting. And now finally we have a system that we see is essential for the proper working of all the other physiologic systems. So
oh yeah, and I forgot to mention, so you've kind of brought cannabis back into that larger public health discussion. There's an amazing researcher at University of Indiana, and I'm blanking on his name. He was the one that first published some of those studies on the link between cannabis use like 3 times a week. And Ethan was mentioning it in his talk about the population studies that were showing cannabis reducing BMIs, obesity. I think Ethan said 3, like on average, if people had used some form of cannabis, and I think it's THC containing cannabis 3 times a week, or have some frequency like that, then that in general their metabolic function was improved. And so the guy that published that, and I'm blanking on his name right now, sorry, I can pull it up, but he's pretty brilliant public health professor there at Indiana, and he actually has done a much larger analysis of what kinds of public health benefits there would be based on all the studies he collected, epidemiologically, cancers and heart disease and neurological conditions. And he was able to like kind of extrapolate from that based on like what we know. And again, there's always like a little bit of fuzziness when you extrapolate from 6 data sets to a larger population, but that's part of the whole field of public health, is how to actually make those in a way that's reasonable, controlled, and within whatever limits. But see, he did that. You can like find his entire analysis, and he showed how many less deaths there would be if the population, if this was available, the population level, and he put in a bunch of data pieces. Like it's like a big data analysis, like even those Medicare data and everything. How many thousands of less people would die from cancers, heart disease, a few things. And it was really it's a brilliant data set. And he sent this off to a journal and it was accepted. They were going through the process, accepted with revisions is what they said. And so then he was making the revisions, and then some other like editor came on, and they reversed their decision and completely rejected. And so it was so controversial, even though if you look at it, like the data analysis is very sound. I think it was like, I forgot which journal, like the BMJ or some mainstream public health journal. And so then University of Indiana has like the library has something called ScholarWorks, where it's kind of preprints, or like any research you're working on, you can just publish it like through the library. And so all of that is available to, and he has all the correspondence with the peer reviewers, so you can see like the total bullshit that they did. I couldn't believe it. Yeah, so I cite that guy and those findings in that chapter because I think that he was onto something so big. That's just one botanical medicine, and of course it has to be available, accessible, clean, the right types, so many different things involved, but really like that's what the scientific analysis can show you, and we actually hear the numbers. I thought that was really cool. You can sort of say public health will work, but like how much and relative to other interventions. So that's the kind of thing that I think public health can bring to the public debate. And I think people like doctors, people who are health, like, look, I mean, I can't believe Anthony Fauci is like on Time magazine. Like he's this like, geeky specialist doctor. I used to work with him when I was in my year at NIH. We did rounds with him on the 5th floor, allergy and infectious disease patients, usually patients with like rare immunodeficiencies or like people going through different things. And, I also saw he treated the nurse from Texas who got Ebola. And she was treated when I was at NIH. And I got to see the press conference where she got out after like being treated for Ebola. And Anthony speaking, Dr. Fauci, this nurse, she was really like still needed to rehab a lot from that. And anyway, like he was a real legitimate like ID doctor. And he kind of gave us a talk about like, like advising presidents on HIV/AIDS and what it was like, and meeting in an Italian restaurant in Bethesda where it was like some big tea meeting, and he was like using like the original Godfather movie where there's like a meeting in an Italian restaurant as like his like the way he tells the story, because it's very much like that. I don't know if you guys have seen that movie, but there's like a key thing that happens in an Italian restaurant.
I'm going to have to jump off because I have another Zoom conference right at the top of the hour, but you guys should go ahead and finish this line, and then I can listen to the recording.
Oh yeah, that's good. I was just saying, the point of that whole thing was just like doctors really are like that kind of doctor is being listened to because he knows infectious disease, and he's like making really sound things for the public. And I really feel like if we had some other kind of like, infection expert on endocannabinoidology, advising the nation, how to care and feed
between you and Ethan Russo.
Yeah, guys. Well, we'll have to have a committee.
Right.
Anyway, I really have to run because
that
I've
was
only
a
got
real
like 2
pleasure.
minutes and
Really
I have
good
to go look like a
guys.
doctor in this other video.
Good to meet you. See you, Karyemaitre. Thanks for doing this. Let's do it again
soon.
soon.
Yeah, we should do it again soon, most definitely.
Really great stuff, guys.
We'll talk about it. We'll plan it. Bye-bye. Yeah, I mean, we if you're going to post this, that'll be fun too. So let's see if we get any.
I'm so excited to post this, Sunil. It's gonna take me a week or two to get the editing done, but really great stuff. I mean, who's gonna be interested in this kind of nerdy stuff? I don't know, but at least we'll put it out there. Somebody will like it. I guarantee you that.
Yeah, I mean, I haven't even got a chance to read your last paper you put out a little while ago. A very comprehensive view. I forgot where you put that out at, but it was really interesting. I started looking at it, but then
really?
What was it? Could you remind me what that was?
Do you remember? Was it in a peer-reviewed journal or was it another article?
It could have been. I'm not sure. It was an article. I don't know if it was peer-reviewed or not, but you said it was like
I went through. I did with Jamie Caroon. I did most of the legwork, but he's just a way better editor and good with the peer-reviewed process, and was the lead author. But we went through CBD at the time and looked at every single receptor system that it interacted with, and we documented it. And
oh, that's what it was.
Our feedback was, oh, you should have this. This should be a chapter in a textbook. But I did a paper on cannabis in the GI system. I just wrote one on cardioprotective effects of CBD, because a lot of folks are afraid of prescribing THC-based cannabis with cardiac patients because there's, increased heart rate, et cetera, et cetera. So I was like, well, let's look at CBD. I did a kind of a controversial one that I'm afraid to post on LinkedIn on cannabis and pediatrics because I'm not a pediatrician, but there's certainly a role for it, and that's not my area of specialty. I did one on PTSD just because I was very interested in it. I've put about an article out a month since the beginning of the year. And my goal is to take all of them and rework them into some type of a textbook. So or a book of some sort. I might even do 2 books, one more academically oriented and then one more for, just the average folks. So.
Wonderful. Yeah, I'm excited to see Dustin Sulak's new book too. I haven't gotten it yet, but I think the book is going to be excellent.
Fantastic.
He has a lot of wealth of knowledge too. So you probably,
I met him once at a conference. He's a great guy. He was really nice too. He came up after my talk and said, "Oh, that was so interesting." And he's really just a great guy. So
absolutely. Yeah, I've known him since he was a medical student. We were students at the same together, different programs, but connected through some of these national listservs. And it's remarkable, like how far, from those days when we were just sort of talking to our peers about cannabis. Now he's this written a textbook, incredible.
The old days of Hemp Fest.
Right.
I think that we did attend the very last Hemp Fest. I don't see that.
I think that's right. That's pictures where people were sharing because it's a couple of years anniversary. 2 years ago now, I think is when it was, which is.
I met your eldest son there. He was very interested in trains at the time, if I remember correctly.
That's right. Yeah, now it's planes, and so it changes. Well, listen, it's been really, really good to connect.
Super good to see you, Sunil. Thanks for your time, your wisdom, your generosity with your time. I know you got a lot going on. Let's try and get the 3 of us together again soon. I will send you links to the raw audio as well as the podcast when it goes up.
My gosh, thank you, Jake.
All right, buddy.
You're so awesome, man. Take care.
All right,
Have a good
talk soon. Okay, bye.